everybody. Thank you so much for being here. It's such a pleasure to be here and meet all of you. And this is my first time to Alabama, so it's great to also be here and meet everybody that I have never crossed paths with before. So I'm going to talk to you today about the maternal mortality crisis, with an emphasis on the progress that's been made so far and what the next steps are. I don't have any relevant disclosures. I'm starting with this slide to really set the stage for talking about maternal mortality in the United States. We need to know that we have made tremendous advances in maternal mortality over the past century. Okay, this is truly a public health phenomenon that should be recognized and celebrated. You know, we went from about 850 deaths per 100,000 live births in 1900 to less than 50 per 100,000 in the 1990s. The problem is that after that, we started to see an increase again. And what you can see on this graph is that we're really having a slowly rising maternal mortality rate since the early 1990s. And appropriately, that's raised alarm as to what has changed to reverse our trend in reduction in mortality and what we can do in the United States to eliminate preventable maternal deaths. So this graph really starts where that previous graph left off. And you can see the United States is in black, and we're having a climbing rate, while other developed regions in blue continue to have a decreasing rate. This is just another graphical depiction using WHO data to demonstrate the United States ranks 47th in the world for countries where the fewest women die while pregnant or shortly after pregnancy, which is clearly unacceptable. So as you all know, one does not have to look far to find media coverage of the maternal mortality crisis in the United States. While this focus from the media on maternal death is extraordinarily helpful, it's imperative in educating the public and creating momentum for us to move forward, there's really been very little attention to ongoing efforts that are happening across the United States at both the state and national level to try to address this problem. And so I want to review with you guys today as well some of the successes that we've made and the steps that are happening, because this is certainly not being ignored by physicians or women or their families. So this first part of the talk is just a little bit tedious, so I just need you to bear with me for just a few slides so that we can all be on the same page in terms of what we're talking about with terminology related to maternal death. It is complex. Really, technically, it's a ratio, not a rate. You hear those terms used interchangeably, and I will probably slip and use them interchangeably at some point in this talk. But it's the number of maternal deaths per live births. So the reason it's a ratio is because that numerator includes pregnancy losses, women who are dying of ectopic pregnancies that wouldn't be included in denominator of live births. And it's not uniform. Which cases are being captured, how they're being captured is not uniform across the United States or across the world. There is a WHO definition that's used in many countries, which is the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. There are CDC definitions that are utilized in many maternal mortality review committees across the United States, including Colorado and Utah, where I've chaired the committees. And those are the two that I'm going to use during the talk, and that's the next two definitions here. So one is a pregnancy-related death, which is the death of a woman during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy, okay? So if this woman had not been pregnant, she wouldn't have died. That's what this is trying to get at. And then there's pregnancy-associated death, which is the death of a woman while pregnant or within 1 year of termination of pregnancy, regardless of cause. So pregnancy-associated deaths really make up the whole universe that we're looking at with maternal mortality. So this includes women who had a motor vehicle accident completely unrelated to their pregnancy at 6 or 7 months postpartum and die. Okay, that's still pregnancy-associated death because it was within 1 year of the birth. And so those are the distinctions, pregnancy-associated versus pregnancy-related. So how do we ascertain maternal deaths? Traditionally, this has been done through vital statistics. So the National Center for Health Statistics, the Pregnancy Mortality Surveillance System. But now there's really a lot bigger push to maternal mortality review committees, and MMRC is then bringing that data in a standardized way to the national level. So it's really exciting to hear that Alabama has started an MMRC, and I look forward to hopefully meeting some members of the MMRC today over lunch. MMRCs bring increased ascertainment. So how do we find maternal deaths when we sit on MMRCs, maternal mortality review committees? We're linking birth and death certificates. We're using death codes related to pregnancy, which you guys, many of you probably know as O codes. We're using the pregnancy checkbox on the death certificate, and we're going to talk more about that. But on death certificates, there's a spot in all states except for California where you check a box to say that the person has been pregnant within the past year. There's hospital reporting where hospitals can report directly to MMRCs. There's coronary reporting, and we scan the media for media coverage of maternal deaths. So as you can imagine, people are getting these and finding them in different ways, which creates issues with ascertainment. You know, when we rely just on vital statistics, we can miss cases, but we can also overcapture with things like death codes and the pregnancy checkbox. California still does not use the pregnancy checkbox, so we can't use that for a national rate. And other states have phased in this recommendation over a period of many years. And these are the issues that have led to this idea that I'm sure you guys have heard about. The U.S. hasn't reported a maternal death rate since 2007. That's true, and it's because we have all these different means of ascertaining it. But I did hear at a conference I was at last week that they plan to release one this year, which is really exciting. So, as I just said, due to this differential reporting, we have not, among states, there's no true MMR in the United States since 2007. Some investigators have evaluated this and tried to determine whether the maternal mortality ratio is truly rising or if instead we're just doing a better job of ascertaining these deaths, identifying these maternal deaths by using these different means. These authors and others note that there's definitely differential reporting among the states, with some using the pregnancy checkbox and others not using it. These authors actually conclude that most of the increase that we're seeing in maternal mortality is due to an increase in ascertainment. The maternal mortality ratio that they found was 7.55 in 1993 and 21.5 in 2014. That's that increase you see on the graph. But they found this was mainly due to two new ICD-10 codes that came in over that time period, which were renal disease and other maternal diseases classified elsewhere. And that if they excluded these deaths with these new codes, there wasn't actually an increase in the maternal mortality ratio. They did a regression analysis to adjust for ascertainment, and they found no increase. And in the checkbox states, what they found is that when we included those pregnancy checkboxes to ascertain these cases, the maternal mortality ratio was 22.4. In the states that weren't using that checkbox, it was 9.9. So we clearly had an increase in capture of deaths by adding this checkbox to the death certificate. And they conclude that 90% of the change was due to ascertainment and that 30% was due to misclassification. Other investigators have looked at this and disagree. Marian McDormand has done a lot of work in this area, and this is one of her papers. She used correction factors to adjust data for the addition of the pregnancy checkbox and still found a persistent 27% increase in maternal mortality from 18.8 to 23.8 per 100,000 live births from 2000 to 2014. Importantly, her study excluded California because they weren't using the checkbox, and Texas because they had such a sharp uptick over such a short period of time that they thought it was probably a spurious result and was probably an ascertainment problem. And it turns out that subsequently Texas has published several papers saying that that is true, that it is errors in coding from that checkbox. So these authors said it's an international embarrassment the United States since 2007 has not been able to provide a national maternal mortality rate to international data repositories, such as those run by the Organization for Economic Cooperation and Development. This inability reflects the chronic underfunding over the past 2 decades of state and national vital statistics systems. I think we would all agree this is embarrassing. So how do we tackle this? Why aren't we seeing anything come out? Why isn't the needle budging yet? And what I would argue is that it is. I'm going to talk to you a little bit about the progress that's being made. So progress made. We're going to be positive. There's a lot of things that have happened over the past 5 to 10 years to tackle this issue. There's been development of infrastructure to fund and organize maternal death reporting. There's been support for maternal mortality review committees in every state. There's standardization of reporting for aggregation of data at the national level, and we're going to talk about all of these a lot more. And there's an opportunity for assessment of preventability with recommendations for action, right? Because ultimately we can collect all the data we want, we can observe all the trends that we want. Unless we're taking that data and actually acting on it, we're never going to see a decrease in maternal deaths. So what's the infrastructure that I'm referring to? There's something called the Building U.S. Capacity to Review and Prevent Maternal Deaths, which is a partnership between the Centers for Disease Control and Prevention, the CDC Foundation, and the Association of Maternal Child Health Programs, which is funded by Merck for Mothers. Merck for Mothers funded and established a new maternal mortality committees, funded the collaboration between established and new maternal mortality committees to improve infrastructure at the state level. We were part of that in Colorado, and we were partnered with Delaware, which was an emerging committee, and the whole goal was for established committees to help emerging committees get together and be able to facilitate maternal mortality review in more states. There's ongoing interaction between CDC partners and state committees all over the United States. There's 42 states, 1 city, and 1 U.S. territory that CDC is currently working with closely, which covers 92% of the births in the United States. So we are really getting there. And I work a lot with CDC and CDC Foundation, going around and talking to people about how to start MMRCs, how to address barriers that they're encountering. There's been creation of a tool called Maria, which is the maternal mortality reporting information, standardized case form, which basically is a tool that I'm sure that if you're on the MMRC here, you've seen, where you basically go through a tool, it guides you through how to review a maternal death, and then submit that data in an aggregated fashion to the CDC so that they can do analyses ultimately at the national level. So this tool really does walk committee members through all the available documents for each case, and we're actually going to go through an example of this. And then the committee members can make a determination regarding whether that death was pregnancy related or pregnancy associated, right? Did the pregnancy matter, or was this just incidental and temporally related? Was it preventable? And then make recommendations moving forward, which is what we really have to be able to do. So who cares? Why is that a big deal? Well, it's a big deal because for the first time, we were able to put out this report from 9 committees that Dr. Wingate referred to. And we were able to take maternal death reporting from 9 different states and aggregate it and actually get shared data, which really sets the stage for being able to say that if we can do this in every single state at the state level, that these data can be brought together and we can ultimately report a national death rate. These shared data were from 9 states with existing committees, so they came from Colorado, Delaware, Georgia, Hawaii, Illinois, North Carolina, Ohio, South Carolina, and Utah. And the CDC aggregated the causes of death, and they also had assessed preventability using the standardized data collection form. For this report, there were 680 pregnancy-associated deaths that had been reviewed. Okay, so death in pregnancy or within 1 year of the end of pregnancy. It was determined by the review committees that 35% of these deaths were pregnancy-related, meaning if that woman had not been pregnant, she would not have died. And 60% of the cases were thought to be preventable. And this is what you see in the media a lot, right? These deaths are preventable. It's true, but they're preventable in a multifactorial, multi-pronged fashion. And I think that when we go through a case, you'll understand what I mean by that. It's not an easy solution. We're all going to have to work together. Deaths from hemorrhage and cardiovascular disease were most likely to be classified as preventable. Okay, we have interventions for these things. They often happen in the hospital. Those are opportunities for us to intervene. And there were opportunities to alter outcome at both the clinical, non-clinical, and public health systems levels. And I know that we have stakeholders from all of those arenas here today. So what did we find? Well, there were contributing factors at the patient, family, healthcare provider, facility systems, and community level. Most of these cases were multifactorial. On average, at least 4 factors were identified contributing to that death. And for those of you who have reviewed deaths, you see this, right? This is a Swiss cheese model. It wasn't one thing. It was the 10 things that happened in sequence before that death where there were many opportunities for prevention. And we also know that we need involvement from multidisciplinary stakeholders moving forward because these are multifactorial and because they do involve many different contributing factors. What were the most common aggregated causes of death? Hemorrhage topped the list still, along with cardiovascular and coronary conditions, followed by infection, cardiomyopathy, embolism, preeclampsia and eclampsia, and mental health conditions. The causes of death really varied by race and ethnicity. The top 5 causes in non-Hispanic white women were cardiovascular, hemorrhage, infection, mental health conditions, and cardiomyopathy. While the top 5 causes in non-Hispanic black women were cardiomyopathy, cardiovascular, preeclampsia and eclampsia, hemorrhage, and embolism. I could give a whole talk for many hours, honestly, about the disparities with maternal mortality in the United States between Black and white women. They absolutely exist. I'm going to briefly review that data, but I cannot do it justice in the short period of time. There is absolutely racial disparity. It's persistent. The reasons are not clear. There are U.S. data sets from 2013 to 2014 from 27 states that demonstrate a 2.5-fold increase in maternal mortality for non-Hispanic Black women, and we see similar data in the UK. This is not just a U.S. problem. Black women had a relative risk for death of 4.19, which is a huge number when you talk about relative risks. These are data from Marion McDormand's group again, who's done a lot of work in this area, and you can see rate among Black women is much higher than any other racial or ethnic group. These reasons are probably very complex. This is not due simply to poverty or reduced access to care. There's chronic stress that people worry about. There's comorbidities, obesity, poor care, miscommunication with healthcare providers. There's a higher case fatality rate, and people think there's a large role of unconscious bias in these cases. And you hear these women talking about this. I told them that there was something wrong, and they didn't listen to me. And we hear that a lot more often from Black than white women, and it is a major target for future research. Women who are Black tend to die more frequently of cardiovascular disease, VTE, and preeclampsia. Also importantly is that only 2 states had the same 3 leading causes of maternal death. So we say we all want to push for this national aggregated rate, and what are our national causes of death? I think that is obviously extraordinarily important, and I've already talked about that, but this also demonstrates the importance of maternal mortality data at the state level. All states are different. All states have different leading causes of death, and so if we're going to put action towards these items, you have to know what's causing death in your state. Colorado, when I was in Colorado and chaired that committee, we looked at maternal deaths from 2004 to 2012 in our state, and suicide and accidental overdose was by far our most common cause of death, followed by motor vehicle crash, non-cardiovascular conditions, and so forth. Same thing in Utah. 3 most common causes: drug-induced, 26%, followed by VTE, motor vehicle crash, and most commonly this is opioids that women are using that are prescribed. So a lot of what we review in the Colorado and Utah maternal mortality review committees are overdose and suicide cases. I'm going to actually run through one of those for you, and I think it is illustrative of how any maternal mortality review committee reviews a case, okay? And this is a fictitious case. This is something that the CDC has put together with input from a lot of leaders in national maternal mortality efforts, but this is exactly what we see when we review these deaths. So for those of you who haven't sat on an MMRC committee meeting, what we do typically is we have somebody who's an abstractor, and that abstractor has gone through all of the records from that patient that we have, and they basically create that patient's story. And we review the patient's story, and then we make determinations related to it. And so we're really highly reliant on that abstractor, who usually works for the Department of Health, to go through these cases in detail and tell us the story. And so this is what it typically looks like. So there's a 22-year-old G1P1 at 2 months postpartum who was found unresponsive by police after her mother called 911 when she did not answer the phone. She was administered multiple doses of naloxone, which were ineffective. She never regained pulse or respirations. Time of death is unknown, but was probably greater than 4 hours prior to her being found. And the cause of death was found to be unintentional/acute fentanyl intoxication. This patient began her prenatal care at 20 weeks, so we really want to understand everything that happened to this patient, right? She was unaware that she was pregnant until her boyfriend told her she looked, quote, knocked up. She disclosed injection drug use. She was referred to methadone maintenance program. She has a known history of childhood trauma and suspicion of intermittent partner violence from the father of this baby. She scored an 18 on the PHQ-9, which is consistent with severe depression. She was prescribed an antidepressant and was continued on that throughout her pregnancy. She missed several appointments, which she said was due to transportation issues. They admitted her for observation at 34 weeks with vaginal bleeding. There was concern again for intimate partner violence at that time, and then she delivered her baby at 36 weeks gestation. Her infant had mild neonatal withdrawal, but did well without pharmacotherapy. Her antidepressant was refilled at the time of discharge. She missed her scheduled postpartum visits at 2 and 6 weeks, and per the practice policy, a no-show letter was sent to her last known address, but no other attempts were made to follow up with her. At 6 weeks, she lost Medicaid coverage, which is the case in both states that I have worked in, and she dropped out of methadone treatment due to cost. So how do we tackle problems like this, right? We see these cases and we go, oh my gosh, that's so sad. There's so many levels on which that could potentially have been prevented, right? Well, I think MMRCs have a really unique ability to make recommendations to prevent deaths, in this case from mental health conditions and substance use disorder, but really any kind of disorder. And hopefully I can demonstrate that to you as we go through this and how we would deliberate this case. So the most important thing is assessing your MMRC membership to ensure that you have relevant expertise needed to review, in this case, substance use cases, but anything that you're reviewing, right? So when we review substance use cases, we make sure we have a perinatal psychiatrist there. We have prenatal care providers who really specialize in serving women who have substance use disorder. We have opioid grantees, and we have community providers of support services and medication-assisted therapy. So really try to get all the stakeholders there. If you're reviewing a cardiac case, you'd want your cardiologist there. So even if it's not somebody who is a long-term member of your MMRC, sometimes we bring in special experts for these cases where we really need that expertise. And the details are really important, especially in maternal health case review. Was substance use and other mental health disorders disclosed? Was a treatment plan initiated? Was a treatment plan followed? Were there barriers to accessing resources like this patient identified with her lack of transportation? So how does this look when we all get together? And if you guys go to the CDC website, you can actually see some mock maternal mortality review deliberations that are posted there. And this is some output from that. So the committee always has a lot of questions, right? We present these cases, we hear the woman's story, and then there's always more. What were the results for autopsy? Were there any special medical examiner notes? Can we find anything in the prescription drug monitoring program? And some states do have access to that for the purposes of maternal death review. Were any ER visits, prenatal cares, or hospitalization records that showed she was screened for substance use? Was she referred to a mental health provider? What stressors were present before, after, and during her pregnancy? Was there any record of drug charges filed against her in the past? And does she have stable housing? And why didn't anybody screen for domestic violence? And so really trying to understand the community in which this woman lives. How do we get at this, right? What are our data sources? It's much more than just vital statistics. We ask for their prenatal records. We ask for any hospital records. We get the autopsy. We're working with our coroner to try to encourage autopsy in cases of unknown etiology of maternal deaths. We are accessing the prescription drug monitoring program. We're getting child welfare data, police, sheriff, court records, other mortality review systems. We look at the violent death reporting system, local overdose fatalities, and fetal infant mortality reviews and child death reviews. These other systems might already be reviewing the same or related cases, and you can combine resources. So what's the value of that? Well, we can save time gathering records, take advantage of existing local partnerships, and minimize duplicate record requests to the same place from multiple systems, right? We don't want to cause fatigue within these hospital systems that are providing us with these records that are so valuable in reviewing these deaths. What are the challenges? It really requires coordination of variable processes. The timelines for case review can be very different. And depending on the statute within your state for reviewing these cases, you may or may not have the protection you would like, and sometimes states then operate on a delay for review of these cases that are potentially still in litigation. So when we circle back to our fictitious case, we were worried that this death was preventable. There was really poor coordination between obstetric providers and medication-assisted therapy providers. There was inaction when the patient presented with third trimester bleeding and no screening for suspicion of intimate partner violence. Patient was discharged without psychiatric or primary care transition. She was lost to postpartum follow-up, and she lost her medical insurance. So this is what the Maria form looks like when we deliberate these cases and deliberate a case within the MMRC. It's really a detailed process for each case. And what it asks is, was this death preventable, yes or no? And what are the chances to alter the outcome? Good chance, some chance, no chance, or unable to determine. And you'd think this would be easy. This is not easy. This is hard. And it's really hard because it's like, how big of a scope can we take on? And I think that the overriding idea is that we want to take on a big scope. We have to tackle all these issues. And maybe that can't be tackled by this particular provider. But in the grander scheme, what do we need to be advocating for to help prevent preventable maternal deaths? And you'll see that there's things at the patient, family, provider, facility system, and community level that can be identified as contributing factors. And then importantly, next to it, it says, what are the recommendations of the committee? How are we going to capture what our recommendations are that would help prevent this death in the future? In this case, depression and intimate partner violence are strongly associated with opioid use disorders in women, and prenatal depression is highly predictive of postpartum depression. This was a woman at risk. We knew that early in the pregnancy, and we needed to engage her in care. Postpartum women do have an increased risk for overdose, and that's because we have physiologic changes of pregnancy that resolve, decreasing volume of distribution, rate of drug metabolism, abstinence from illicit use of opioids during pregnancy decreases tolerance, then women return to use after pregnancy, and then they overdose at the same level of use that they had previously. Untreated mental illness is a known trigger for relapse, and loss of insurance often results in cessation of treatment, as was this case. So what are the recommendations? Again, this is where you engage your multidisciplinary committee, right? Public health can promote peer recovery. Stakeholders should advocate for increased access to treatment programs for women with substance use disorders in pregnancy and postpartum. Facilities need to educate providers on screening for substance use, depression, intimate partner violence. The Perinatal Quality Collaborative can promote obstetric and medication-assisted therapy, provider coordination, and patient contact. The community should advocate for naloxone distribution to patients with opioid use disorder and their families, and stakeholders should advocate for postpartum coverage that extends to a minimum of a year. These are broad, right? Super, super broad, but this is how we capture what the problems are. And importantly, what they say is, what is it and who can do it? And that's the only way that we can get at intervening on behalf of women. So what's happening now? Is there anything happening now? And the answer is yes. The American College of OBGYNs is really working to redefine postpartum care. We don't just tell women anymore, great, you had your baby, we'll see you in 6 weeks. It's the idea that the mom was talking about in that video, right? Educating women about what is normal, following up with them when they need follow-up instead of this arbitrary 6-week mark when probably they needed all the follow-up before that and we didn't see them and they were struggling with it alone. And it's interesting when you talk with pediatricians about this, and I don't know if there's any in the audience, they'll say, oh, thank you. Like, you guys just dump them on us, right? Because we see these moms all the time with their babies, and nobody's worrying about the mom. It's all about the baby. And then pediatricians are screening for postpartum depression in moms, which we certainly need to engage and work together in a collaborative relationship like that, but we also need to take responsibility for working in that arena. So really redefining the goals of maternity care, from achieving a favorable pregnancy outcome to supporting the transition to parenting. Multidisciplinary, team-based, integrated, co-located care for moms and babies. So how do we determine if a death was pregnancy related? Okay, and this is a reminder. Death of a woman during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. The question that our committee always asks is, if she had not been pregnant, would she have died? And if you circle back to that every time, that can sometimes help delineate these cases. What really was pregnancy related? It's hard though, like with overdose cases, well, we know that mental health, intimate partner violence, stress, drug metabolism, those are super closely linked to pregnancy, right? And so in many cases, you could say that potentially if she hadn't been pregnant, she wouldn't have died. The CDC recognized the importance of a lot of contributors to maternal death and has added some of these to the Maria form. So this is also on the Maria form. Did obesity contribute to the death? Did mental health conditions contribute to the death? Did substance use disorder contribute to the death? Was it a suicide? Was it a homicide? And if it was, what was the means of fatal injury? So this is filled out on every single death that's reviewed now. So what are the next steps moving forward? And what's the Alabama MMRC committee going to do? What's the Utah committee that I'm on going to do? We really need to expand data collection using Maria, so using the standardized form so we can aggregate national level data. And we've demonstrated proof of concept for this with the 9-committee report. And we need to translate state level recommendations into action, right? Again, just reviewing this, just producing data isn't getting us where we need to go. It's time for action. And we need to eliminate preventable maternal deaths. How are we doing this? There are some efforts already in this regard. There's National Partnership for Maternal Safety that's put out priority bundles related to hemorrhage, hypertension, and VTE. And there's a big national network called AIM that has worked to help implement these sorts of bundles. There's unit improvement bundles, so recognition of maternal early warning signs. When women have abnormalities in their vital signs that should trigger a response, that's being integrated into medical records, that's being integrated into nursing education. So that when we hear these stories about these women that, by the time I came in, I was so sick, I couldn't see anymore, and my body was shutting down, right? Trying to catch those processes earlier and take action in an objective way, trying to eliminate unconscious bias, trying to reduce the disparity gap. Internal case reviews, not just reviewing maternal deaths, but also reviewing severe maternal morbidity. So identifying women at your hospital or in your hospital system who have been admitted to the ICU or have received 4 or more units of blood are really markers that are easy to identify women who had major morbidity that was really a near-miss experience, reviewing those so that doesn't result in a mortality the next time it comes up. And then support tools for families and staff, like we talked about, things integrated into the medical record, and information for moms, right? There's a new cardiovascular toolkit that California has put out that has a whole section about, here's a patient handout. This is what we should tell patients. This is a problem. If this is happening to you at home, you should come in. It's not just congratulations, here's your ibuprofen, and we'll see you in 6 weeks. Really educating women about warning signs, things they should come back to the hospital for. This is a Council on Patient Safety and Women's Healthcare bundle on maternal mental health, perinatal depression, and anxiety that's available. These tools are out there and accessible. There's a partnership between ACOG, SMFM, and CDC to look at levels of maternal care. And this is probably something that your PQC has been involved in. But really what they want to do is identify appropriate levels of care for women depending on what their pregnancy looks like, right? And so the CDC implemented this level of care assessment tool to help determine the maternal levels of care for all birthing facilities. And this goal is to get women to deliver an appropriate birth setting based on individual needs and level of risk. It is not a goal, the goal is not to have every woman deliver at a high-risk hospital. The goal is to have women deliver where they should deliver based on their level of risk. And they've really started to do some maternal level of care verification programs. They've piloted this in Georgia, Illinois, and Wyoming. And then Chris Zahn, who works for the American College of OBGYNs, wrote an editorial about this in the Green Journal in 2018 with how their pilot is looking and how they want to expand this across the United States. And so I think there's going to be a lot of opportunities to get involved with that as well. And thinking about the hidden context of the prenatal visit. What is that patient's social environment? What are the family dynamics, the pregnancy and the postpartum period? What do they bring to that visit with them? It's not just, is the baby moving? Are you bleeding? Are you having contractions? But how did you get here today? What's going on at home? What can I help you with? Really looking at women as a whole and also looking at women across their reproductive lifespan. So we talked about this, last week when I went to the NICHD workshop on maternal mortality research to try to really delineate areas that we should be moving forward related to maternal mortality. And one thing that came up over and over again was that this is just one piece of this. We need to be advocating for women throughout their lifespan, and that many of these things that are predisposing women to maternal death have nothing to do with the pregnancy time period itself. It's things that have come up much earlier in life, and not just focus on such a narrow window. And I think, the final point is really that maternal death is just the tip of the iceberg. That's where we're starting. That's what maternal mortality review committees are starting with. But, Utah now, we are expanding our scope. We're going to try to review statewide maternal morbidity. And I have an extremely motivated partner who has some funding to start doing that. And she is trying to sort of lead the way with how can we identify morbidity across the state? How can we narrow that down to what needs to be reviewed by a committee? And how can we really get down to the roots of what's happening? So the deaths are the top. The near misses are the women that you heard from in the video. Below that is women who had severe maternal morbidity, but they did fine and they weren't really that bothered by it, but we should be. Women who maybe just required a hospitalization or an ER visit or even just a primary care and extra specialist visit that they didn't need because we could have intervened before that happened. The long term is really to eliminate preventable maternal deaths, reductions in maternal morbidity, and population improvements in the health of all reproductive age women. I am incredibly thankful to all the CDC staff because many of these slides and cases also come from work from them, which they allow me to freely work with because they also really want to get this information out there, specifically Dave Goodman, Julie Zaharatos, Nicole Davis, and Amy St. Pierre. Merck from others who funded the Colorado review, which really helped us move a lot of this forward and start to aggregate our data. The Colorado MMRC, the Utah Perinatal Mortality Review, and then all these other contributors, Camille, Elliot, Bill, and Bob. This was the commentary that Dr. Wingate referred to, where I talked about eliminating preventable maternal deaths in the United States, progress made, and next steps. And really that closed with, let us celebrate our successes while remaining clear about our direction moving forward. I'm not trying to say that we have made progress and we can stop. I want to say that we have made progress and we need to continue. There's a lot of room to grow and make a difference in preventing maternal death in the United States.